Renal disease in pregnancy.
Welcome to your guide to renal disease in pregnancy. The urinary system is a waste disposal system. You have two kidneys which drain urine through tubes called the ureters down to the bladder, which stores it temporarily before emptying it through a tube called the urethra.
The kidneys are complex organs with 5 main functions. They are equipped with millions of filters called nephrons, which continuously filter out excess fluid and waste products such as urea, potassium, creatinine, sodium and chloride from the blood and discharge them as urine. The kidneys also produce hormones, including erythropoietin, which helps to produce red blood cells, calcitriol, which helps maintain healthy bones, and renin, which helps maintain a healthy blood pressure. In renal disease, when the kidneys are not working well, waste products such as creatinine build up in the blood. Protein and blood can leak into your urine. Blood pressure climbs higher and higher. Kidney stones can develop, and urine infections can occur. The urinary system changes in pregnancy. Extra demands are placed on the kidneys. More blood is sent to them, and they must increase the glomerular filtration rate. The kidneys also produce more hormones and hold on to more sodium and water. Also, the tubes of the urinary system dilate or open up, which is thought to be due to the hormone progesterone. This means it's easier for bugs to find their way into the urinary system during pregnancy, and so urinary tract infections are common. At every antenatal clinic visit, your urine will be checked for signs of bacteria. 7% of pregnant women will have bacteria in the urine without any symptoms. It is important to find and treat this asymptomatic bacteria to prevent progression to symptomatic urinary tract infections and pyelonephritis, as those more serious infections can lead to preterm delivery and low birth weight babies. Urinary tract infections are more common if you are diabetic, on steroids, immunosuppressants, or have a history of recurrent urinary tract infections. You're not alone if you have chronic kidney disease in pregnancy, as it affects 3% of women of childbearing age. Chronic kidney disease is characterized by a progressive deterioration of your kidney's ability to filter toxins and excess fluid from your bloodstream. Chronic kidney disease can be caused by hypertension, diabetes, and kidney diseases such as polycystic kidney disease. As the nephrons or filters in the kidneys are damaged, the remaining nephrons can't keep up with the workload, and so waste products and fluid accumulate in the blood. Kidney damage is measured by the glomerular filtration rate, which is abbreviated as GFR. The GFR is the amount of blood the kidney can filter per minute. Normal GFR is 120 mL per minute. The GFR for an individual patient is estimated taking their age, creatinine level, weight, gender, and body size into account. GFR does not fall early in kidney disease. It only starts decreasing when more than 50% of renal tissue is damaged. Based on the degree of damage, there are 5 stages of chronic kidney disease. Stage 1 is almost normal GFR, to stage 5, which is renal failure or end-stage kidney disease, where you may be on dialysis or require a renal transplant. Pregnancy can worsen your chronic kidney disease. More protein leaks into the urine, your blood pressure increases, and you can get disease flares or relapses. It can worsen your kidney function to the point that dialysis may be required. Late-stage chronic kidney disease is associated with infertility. Chronic kidney disease makes your pregnancy high risk. You are at increased risk of developing high blood pressure disorders, and this high blood pressure may remain after delivery. Risks for your developing child include growth restriction and prematurity, with the need for intensive care and all that goes with that. A large Italian observational study, the TOCOS cohort, examined over 500 deliveries in patients with various stages of chronic kidney disease and showed that the lower the GFR, the higher the risk of adverse pregnancy-related events such as fetal growth restriction, caesarean section, prematurity, and neonatal intensive care requirements. In general, the level of renal impairment affects the pregnancy more than the type of renal disease. However, immunologic and systemic diseases such as glomerular nephritis or diabetic or lupus nephropathies are more frequently associated with adverse pregnancy-related events. And specific pregnancy risks are reported in various diseases. Babies of mothers with reflux nephropathy can inherit the condition and so are screened post-delivery. Mums with diabetic nephropathy have double the rate of urinary tract infections, preeclampsia, proteinuria, and edema compared to diabetics without nephropathy. If you're unfortunate that severe hypoalbuminemia occurs, risk of pulmonary edema and thrombosis exists. Mums with polycystic kidney disease can be screened pre-pregnancy for polycystic liver disease and intracranial aneurysms, which may cause subarachnoid hemorrhages. There is a 50% chance of transmission to the baby. If you have SLE or lupus nephritis, it is recommended that you delay pregnancy for 6 months following a lupus nephritis flare. You may also be advised to take low-dose aspirin during your pregnancy. Pregnancy itself can cause flares of the disease, which can be managed with corticosteroids. In Rho-positive mothers, the risk of transient neonatal cutaneous lupus is about 5%, and the risk of congenital heart block is 2%. As your pregnancy with chronic kidney disease is a high risk, you will be looked after by a team of specialist doctors, including nephrologists and obstetricians. You will have close monitoring of your blood pressure, renal function, bloods, and your urine will be checked for protein and infection. Your baby will also be closely monitored to assess its growth and fluid volumes. Some of the drugs commonly used in chronic kidney disease to control blood pressure or suppress the immune system can be harmful to the developing baby. ACE inhibitors should not be used during pregnancy. If you have end-stage kidney disease, you may be on hemodialysis or chronic ambulatory peritoneal dialysis. Fertility is reduced on dialysis, so that 1 in 200 women on dialysis become pregnant each year. If you get past the first trimester in your pregnancy, then there is a successful outcome in 50% of cases. Poorer outcomes occur if you are over 35 years of age, more than 5 years on dialysis, and if pregnancy was diagnosed late. Dialysis requirements increase in pregnancy. Both the duration and frequency of dialysis must be increased. More than 20 hours of dialysis per week is often required, spread over 6 days. More women than ever are experiencing pregnancy following renal transplant. Renal function returns to normal post-transplant, and so ovulation, menstruation, and fertility also resume. It is recommended to delay pregnancy for at least 1 year post-transplant. If graft function is normal, pregnancy outcome is excellent, and there is no adverse long-term effects on the graft function or survival. Caesarean section is not required. The transplanted kidney does not obstruct vaginal delivery. Immunosuppressive drugs should be continued at pre-pregnancy doses. Prednisolone, azathioprine, cyclosporin, and tacrolimus are safe for use in pregnancy. MMF and sirolimus are contraindicated. The best pregnancy outcomes in renal transplant patients occur in those with near normal renal function without hypertension, proteinuria, or recent episodes of graft rejection. If baseline creatinine levels are less than 100, the pregnancy has no long-term negative effects on the renal transplant. If creatinine is greater than 130, renal graft survival is only 65% at 3 years. 50% of renal transplant patients will experience pregnancy complications. 27% experience preeclampsia, 8% gestational diabetes, 56% undergo caesarean section, and 46% will have a preterm delivery. Unfortunately, 2% experience graft rejection. Acute kidney injury is uncommon in pregnancy, affecting 1 to 2%. It can be the result of infection, such as puerperal sepsis, and rarely acute pyelonephritis, blood loss, including postpartum hemorrhage or abruption, volume contraction, such that occurs with preeclampsia, eclampsia, hyperemesis gravidarum, or diarrhea, post-renal failure, including ureteric damage or obstruction due to stones, or drugs such as non-steroidal anti-inflammatories or some antibiotics. That concludes our session on renal disease in pregnancy. If you have any questions, please talk to your general practitioner, obstetrician, or a nephrologist.